Dr. Tamara Backhouse is a research fellow at the University of East Anglia. Her research focuses on improving personal care interactions for people with dementia and their caregivers, with a particular emphasis on managing refusals of care in advanced dementia. Tamara, a care worker herself for many years, is passionate about supporting health and social care staff in what can be a tricky area of dementia care practice. Her presentation will share results of the ProCare study.
Thank you so much, and thank you for having me here today. So I'm going to talk about how we can improve patient hygiene for people living with dementia. So who am I? Well, as already said, I am a care worker in care homes for many years. And from that, I did degrees in psychology and sociology. And when I came to do my PhD, it made sense to me to go back to care homes and examine dementia care. And since then, I've been a dementia care researcher based at the University of East Anglia in Norwich, Norfolk in the UK. So today I'm going to talk to you about the ProCare study, and this was a study funded by the Alzheimer's Society, and we examined refusals of care in dementia, but more broadly we examined personal hygiene interactions. So part of this was looking at previous research, and then we conducted interviews with caregivers of people with dementia, and then we video recorded some care interactions where the person with dementia was not fully undressed, so teeth cleaning, washing and dressing of outer sort of layers. And we also used questionnaires to statistically determine what was associated with refusals of care. And this was to develop some support for caregivers. So first of all, what is dementia? Well, dementia itself is not a disease. It's an umbrella term for symptoms caused by many underlying diseases. And there are many types, with Alzheimer's Society, Alzheimer's disease, the most common. But there's also frontotemporal dementia, Lewy body dementia, vascular dementia. And dementia is not an inevitable part of getting older. It's a global issue. So there's estimated to be 944,000 people living with dementia in the UK and 55 million people worldwide. So dementia does not discriminate. You can be fit, unfit, educated, uneducated, rich, poor. Dementia doesn't seem to discriminate at all. So anybody can get it. And there are no cures or effective treatments to stop the diseases that cause dementia. There are some treatments to manage some of the symptoms. And average life expectancy is 10 years. However, it varies widely depending on the type of dementia and the person. So the range is between 1 and 26 years. So how does dementia present? And it presents really differently for different people. Excuse me. There we are. Depending on the type of dementia that they have. So memory loss, I think we're all familiar with memory loss. However, there's also difficulties with thinking, problem solving, language and navigation. So person's communication will be impaired, their spatial awareness may be impaired, and there's also changes in mood and behaviour. And as we can imagine, people experiencing some or all of these symptoms are going to feel sometimes confused or distressed or worried or anxious. So we as caregivers and people assisting them with their personal hygiene need to be aware of this and adapt our approach, because it can be quite frightening for the person with dementia. So our study found some overriding principles for caring for people living with dementia with their personal hygiene, and promoting independence came out as really important, which is not new to most of you, involving the person in the activity in some way. And then observing, prompting and gently reminding if the person was able to still conduct some of their own personal hygiene, and monitoring the person's progress and if they needed more support or less support. Positioning yourself was really important. So that kind of intimidating standing over the person was obviously not ideal. But if the person's seated, coming down to their level, giving enough space so you're not in the person's personal space was really important. Connection with the person was key. Obviously, eye contact, communication, maybe touch, but making some connection so they felt connected to the person assisting them. And making sure you have time for the care activity was key as well. It's very difficult in busy settings, but having that time means that you could take the time to make that connection with the person and think about your position and promote independence. And providing reassurance, which is something that will come up throughout this presentation, was very key for people with dementia. And also demonstrating the activity. So if it was a teeth cleaning, patient hygiene activity, actually making the motion with your hands was really important, because the person with dementia may not understand the verbal communication, but they could see what was required of them visually. So we found that washing, there were several things that caregivers could take into account to improve a personal hygiene activity around washing. A key one was keeping the person warm, and this came out in lots of our evidence. Having a suitable place and position. So is it best if the person, for that person, if they're standing or seated, or is it easier to wash their groin while they're still in the bed? So it's about adapting to the person around the place and the position of the care taking place. Have they got somewhere to sit when they're drying or dressing? You know, where is best for them? Minimising moves was important as well. For instance, if somebody had mobility issues, but also if somebody found it cognitively difficult to understand instructions, having to sit and stand several times during the patient hygiene activity could be difficult and really tiring for the person. So maybe putting on underwear, trousers, socks and slippers and just standing up once could mean that the person could get through the whole activity without being too fatigued. Washing where you can, when you can. So some days people are going to be more receptive to care or not. So it's about doing as much as you can before that fatigue sets in or before the person becomes unsettled. Familiar items were also important. So maybe the person's used to soap and not shower gel, or maybe they don't understand the tap or the plug on the sink. That can be very tricky sometimes for people with dementia. And it's about knowing their usual clothes and things like that. And maybe sometimes you have to prioritise the most urgent activity. You're not going to be able to complete all of the personal hygiene that you want to, and maybe that person's able to just, you know, go through an interaction for 5 minutes or something. So maybe continence care gets prioritised for that day at that time. Showering or bathing or a strip wash. So I've got here the person in the centre, and around them we need to think about warmth, and this is warmth of the person, but also the water and the room, and are the clothes on the radiator or the towels to keep that person warm and comfortable. What's the order of care going to be? If you're showering someone, would it be worth starting at the feet and working up so they don't get cold, or would they prefer to have their hair washed at a separate time to the shower or the bath in interaction? Engaging the person, so making that connection with the person so they don't feel the care is being done to them, it's been done with them, so that there's some connection there. And this linked really key into that reassurance, that encouraging and making sure they know everything's okay, even if they don't properly understand the care activity or what is required of them. Having a friendly, reassuring voice is very key. Obviously, in eye to safety, is there somewhere for the person to sit? Is it okay to get them in and out of the shower? Are you using a shower chair? And dignity, can the person have a towel on their lap while you're showering them? So even if it will get wet, it keeps them covered and lack of embarrassment. Or maybe the person's not fully undressed, so you wash the bottom half first and then sort of cover them up and do different areas at different times. In terms of refusals of care, we have 3 areas really as caregivers where we can make a difference. So we start off with the person with dementia and how they're feeling that day, whether they have unmet needs, what their mood is. We have a caregiver, us, and what our mood is and what our approach is and what equipment we have and things like that. And then the environmental factors. So is it noisy? Is it busy? Is there no time? Is it cold? Have we the equipment we need? And then we attempt to assist with personal hygiene with the patient, and this may be acceptable to them and they're happy to have care, and care goes ahead. Or it might be unacceptable to them and they may refuse. And this is usually for very valid reasons. For instance, I think we'd all refuse assistance if somebody came to undress us and we didn't understand why. So sometimes it can be for very reasonable reasons why a person will refuse care. And at this point, we can employ a care strategy, perhaps encouragement or distraction, and maybe care will go ahead. Or we can leave and return later if it's safe to do so. However, keep leaving care could lead down the road to possible neglect. Or sometimes controlled restraint can be used. And although this is not an ideal choice, it could lead to possible abuse. So there's real difficult consequences, but we generally have these 3 areas in the circles where we can think about our approach, think about the environment, think about what we're doing to try to change the outcome and make it more acceptable for that person. So from the previous research, we found to reduce refusals, playing recorded music was really important and could be really useful. So this could just be calming music, or it could be a preferred music of the person themselves, and it didn't seem to matter in the evidence. Alternative bathing options were really key. So if the traditional tub bath was too daunting, offering a bed bath or a shower, or if the shower was too daunting, offering that bed bath as well. And key communication. So elder speak, so a patronising, slow, maybe high-pitched tone form of communication was linked to more refusals, whereas non-elder speak communication and positive communication was linked to less refusals of care. So from our interviews, we found that finding the right moment to care was really important for caregivers and could be useful. So maybe the person usually has their shower or wash in the evening, so the morning isn't feeling right for them anyway. Or maybe it's coming back after the person's had a cup of tea and woken up more, and then that time is better for them. Using specific communication strategies, so minimizing the sound of the care activity. Oh, we're just going to have a quick wash, or encouragement and explanation really helped as well. Simplifying or adapting care. So this might be, like I've talked before, having that strip wash rather than the tub bath or the shower, or maybe an electric shave rather than a wet shave, or using dry shampoo for a while, or maybe easier to put on and off clothes. Having confidence in care was really important for caregivers. So they talked very much about routine, and they felt very happy in a routine with the person. It gave them more confidence, but also learning more as well. And seeking support from others. So maybe if things aren't going well, getting that extra staff member to support, or calling on external services if things are really not going well. In terms of our observations, we found that in the positive care interactions, which went really well, the person with dementia was participating in care. Now, this doesn't mean they were able to conduct their own personal hygiene. It means that they were either perhaps holding another towel while the caregiver was drying them. They may have been drying themselves, or maybe they were just engaging with their eyes, keeping a watch on what the caregiver was doing, but being involved in that activity. And they were often also seeking reassurance actively or showing apprehension, which could prompt the caregiver to provide that reassurance. So it worked in a positive way. And caregivers were inviting the person to be part of the interaction, so seeking that permission or consent, and working together with rather than doing for. They were putting the person at their ease, so that reassurance was really key, but also showing that they were familiar with the person. So if there was anything they knew about the person, they could link that in, and the person could be reassured, oh, this person knows me. And guiding the person through, so lots of instructions and encouragement. And we found this instruct, endorse sort of communication strategy really key. So the caregiver may say, lift your leg, that's right, or open your mouth, brilliant. And this meant that the person with dementia knew what they had to do if they could understand that. And then straight away, they were reassured they were doing the right thing. So this instruct and then endorse the action worked really well. And caregivers were attuning to space and pace. So it's that non-intimidating positioning, but also not going too fast for the person, but also not too slow for them as well. So some people are more pacey people, and they didn't want slow care. And in terms of refusals of care then, so when you come against those, what do you need to do? Well, has the person got any unmet needs? Are they hungry, thirsty, cold, tired? Are they in need of more control over their care? You know, do they feel a lack of control? You know, what can you do to address these before the care interaction? So it's looking for clues and cues from the person. Is the person unwell? Are they in pain? Have they got an infection? Have they got a temperature? Is there anything there why they're refusing? Is it safe to leave and try again in a little while? And if it is, this is often just takes the pressure off the person when they may feel really pressured from this interaction that they're being trying to be steered towards, that they're not receptive to. And later they may be, once somebody comes back in with a different approach. And so can somebody else try to connect with the person? So is there another staff member who could go in later and try? And can you adapt your own approach? So maybe this person really likes a quieter approach, or maybe a more cheerful and bubbly approach. It's just trying different things. What's going to work for this person today? Because maybe how it went yesterday is not the same as today. And can you adapt the type of care? So we've talked about this, but in terms of a shower, sometimes it can be so heavy on the person's skin, and maybe using the Eco Mist would be a good alternative. And are you able to seek support? So other staff members, but also other specialists who may, if refusals are going on long term, it's good to get their advice and thoughts. So really, what can we learn? We have the person with dementia in the middle, and we need to work around them. So the person with dementia is less able to manage what they need to do and less able to adapt. So it's really up to us to sort of tailor ourselves around the person. So getting to know the person. So maybe with a This Is Me or some life history work or anything in the environment that you can take a cue to link in with that person. And when you've got that, you can make that connection with them a bit easier. Assessing the person's mood before instigating the interaction. And I know time can be difficult, but you can then work out what is appropriate at that time for the person. You know, a whole regime of a bath or a shower may be too much for them, but if you've assessed their mood or whether they have any unmet needs, it's a really good time to do that just before the interaction. And connecting, so it's that eye contact, that communication, the touch. And then adapting our own approaches. How could we go in differently? Adapting the care, adapting the environment. Is it warm enough? So just adapting to the person. And we created a booklet of ideas and tips for carers, which is available free on the link on the slides or on the QR code. So please do access that if you think it would be useful or your workplace might find it useful. And then I just want to say thank you for listening, and thank you to my collaborators from the UEA and University of Sydney, and the study advisors who are family carers and care home staff who advised the study throughout. Thank you.
Thank you so much, Tamara. On behalf of everyone listening, I'd like to thank Tamara for her insight into the ProCare study, focusing on really practical approaches and techniques to assist with delivery and refusals of care surrounding patient hygiene.